Auricle core features. Here we have the live classes, recorded classes, notes as well as MCQs. Meanwhile, you can also use the code Dr. Ankit 20 for discounts on subscriptions. Subscriptions are over here. We have a basic subscription from 15K to standard subscription for 6 months, that is for 30K, and mentorship subscription of 1 year, that is of 50K. Right? These are all the subscriptions over here, and you can use this code Dr. Ankit 20. And these are the topics that we are going to cover up in this today's 1 hour session. So let us come to the topics direct away, and let's start the topics over here. Okay. So the topics, as we said, that it's a general anatomy topic over here. So we'll start with the epiphysis. Okay. Epiphysis, here we have, so to begin with, what is epiphysis? That's obviously quite important. And what are the types of epiphysis? So these are the questions that can come in your theory exam as well as in your Viva OC, right? So we all should be knowing that there's the long bones which we have in our body, mainly of the appendages, upper and lower limb. The long bones have at the ends, those part of the long bones at the ends are known as epiphysis, right? The shaft of the long bone, the middle part is the diaphysis, and the part of the long bone which connects the diaphysis to the epiphysis is known as metaphysis. Basic idea, right? So what is epiphysis? The ends and the tips of a bone which ossify from secondary center are called epiphysis. Here I will tell you a lot of things in between the session or between the points. What are the other questions that can be formed from here? For example, they are saying that the epiphysis are the ends of the tips of the bone that ossify from secondary center. It is ossified. It means that the part of the bone which ossifies from the primary center of ossification, that is what is known as the diaphysis. So do remember that also. Okay, that is also known as diaphysis. So according to the number of epiphysis, there one basic classification is we can call the epiphysis as a simple epiphysis or a compound epiphysis. Very basic differentiation, but these sort of things will help you in writing the exams. Simple epiphysis is when ends of long bones they develop from many epiphyses which fuse independently. So there's not only one center, there are many secondary centers in one epiphysis. For example, let's say we have upper end of femur. Femur is the bone of the thigh. Upper end of femur will have many epiphyses. Now, suppose it has 3 epiphyses, supposedly. Those 3 epiphyses will separately join with the shaft. So that is simple epiphysis. While compound is that when ends of bones which develop from many centers unite. So imagine the same case scenario, and the three centers for the upper end of femur, they first unite themselves, and then they form a single epiphysis, which will then fuse with the diaphysis. That is known as a simple compound epiphysis. Okay, I just gave you femur example, but remember, femur is basically example for the simple epiphysis, and the compound epiphysis, we have the humerus over there as the main example. Okay, now that was simple classification. Other main classification of epiphysis is right over here. That is based on the function. This is quite commonly asked. So we have few epiphyses over here: pressure epiphysis, traction epiphysis, atavistic, which is phylogenetically independent, and aberrant, not always present. And compound, we already have seen that when multiple epiphyses enter, they fuse to form a single epiphysis. So basically, the 4 parts are over here, the new terms over here. Easy to understand. Easy to understand. Let us see. So to begin with, let's finish off. Aberrant it is not always present. Simple as aberrant. Like the epiphysis in the head of the first metacarpal. Okay, normally we have epiphysis at the base of the first metacarpal. Sometimes they can be epiphysis at the head. Sometimes it may be, it may not. Simple as that. That is aberrant. Atavistic over here, it is different species wise. That it is phylogenetically an independent bone, which in humans has been fused to another bone. Simple as that. So that is known as atavistic. The very famous example is your coracoid process in the scapula. Remember that beak-like process coming out from the front of the scapula? That is the coracoid process of scapula. That is basically example of atavistic epiphysis. So 2 are done: aberrant and atavistic. Aberrant, not always present. Atavistic, coracoid process of scapula. Now the 2 other terms over here: pressure and traction epiphysis. Now, how to understand them? Pressure epiphysis are those epiphyses which are given pressure. Pressure was weight pressure. Okay. Traction epiphyses are those, traction means you are pulling something. So in some epiphyses, there are some attachments of some muscles, tendons, or ligaments. Okay. By the pull of those structures, the epiphyseal centers, they form different epiphyses. That is known as traction epiphyses. If you understood this, then you can simply write in your own language. Pressure epiphysis is articular. Obviously, if you are given a weight pressure, it has to be articular. Takes part in weight transmission, example, head of humerus. The head of humerus over here in the shoulder helps in weight transmission of the pulley. Traction is non-articular because here it is not forming a joint. It is actually giving attachment to other structures like tendons or ligaments. So provides attachment to one or more tendons which exerts traction on epiphyses, examples, trochanterus or femur. Okay. Similarly over here, we can understand that femur have two trochanter. One is a greater trochanter, G for greater, L for lesser trochanter, right? In the greater trochanter, mainly what is attached are the muscles. For example, let me give you one or two examples of gluteus medius and minimus. Remember that. These are the main abductors of the hip joint, ABD. At the lesser trochanter, the main muscle that is attached is your iliopsoas, iliacus and psoas major. That is mainly attached into the lesser trochanter. And they are mainly flexors of the hip joint. Just remember this, right? So mainly four types of epiphyses, function-wise: pressure, traction, atavistic, and afferent. Simple compound was a different classification. If this point is clear, let us move to the next part over here. Coming to the basic, what are the bones? Bones, we all know, they are connective tissue and they have a lot of calcium. Okay, impregnated calcium, a lot of connective tissue over there. Simple as that, because they are connections. How to classify the bones? Many classifications are there. Okay, let's see. It is basically, if you have seen the skeleton, if you have gone through the bones and you know the names of the bones, it becomes very, very easy. It's very simple, cakewalk. Suppose in the exam comes like a question like this, and you imagine the bones of the human skeleton. Slowly, you will understand their classification as well. For example, long bones are there. Examples: humerus, radius, ulna, femur. They are long bones. So it has a shaft. It has epiphysis. Okay. Typical long bones, two second epiphysis. Miniature long bones are like your metacarpals or metatarsals. These bones over here, 1, 2, 3, 4, 5, 5 metacarpals. These are miniature long bones. Modified long bones, they don't have any medullary cavities. Say, for example, a clavicle is a modified long bone. Short bones are the bones of the, say, carpals over here, 8 carpals. Mainly 7 carpals are there, but 8th one is a sesamoid bone. So you have scaphoid, lunate, triquetral, trapezium. All those are short bones. Flat bones, for example, look into the skeleton and think of which bone is looking like a flat. It could be a scapula. It could be also, we can talk of sternum. They appear flat. So they form boundaries of certain body cavities. Okay. They can form. That's what the sternum forms a boundary of the thoracic cavity. Irregular bone, hip bone, so they are not long, they are not short, they are irregular bones, right? Hip bone, hip bone. Hip bone, if you have seen, it's made up of 3 different bones. What are those 3 different bones? The 3 different bones in hip bone are your ilium, ischium, and pubis. You have ilium, you have ischium, then you have pubis. These 3 bones, they join to form the hip bone. Pneumatic bones, pneumo means air. Pneumothorax, remember. Pneumoperitoneum, remember, right? Pneumatic bones which are having a cavity inside, not filled with marrow, simple cavity filled with air. That is known as pneumatic bones. Mainly over here, the example that is mainly being taught or understood is the facial bones. These are the facial bones. What is the use of having air in the bone? 2 things. One is that it decreases the weight of the skeleton. Okay. Second thing is that it decreases the weight, fine, and then it also gives resonance to the voice. So each human, if you have encountered, say, 10,000 people in your life, all of them, most of them, they look similar. They have similar height, similar weight and weight distribution. Even then, their voice will be different, right? Even if you talk them on a mobile phone, you easily recognize their voice. If you talk to any person for a few times, okay. Say, for example, you have talked to them for 4 or 5 times, then even if the call after 6 months, you'll be able to recognize their voice if you have a fairly good memory, right? So those are pneumatic bones, mainly the facial bones like maxilla, frontal, all those sphenoid. Sesamoid bones are the bones which are not there in the initial part of development, but as the muscle tendons, they are actually the bones which come from the muscle tendon. So it is a muscle tendon which is when it is rubbing against any bony structure, it forms a hard structure over there that is known as sesamoid bone. So that is sesamoid bone. The most famous example of sesamoid bone will be what? It will be our bone in front of the knee joint, that is a patella. There are many sesamoid bones, mainly 5-6 examples are there, but the largest sesamoid bone is patella, small bone in front of the knee joint, mainly articulating with the femur bone. Accessory bones, they are not always present, but yeah, they can form some extra central ossification. Okay, like your aberrant epiphysis, accessory bones. This is one classification, easier, I guess. Then this developmental classification. Normally, see, developmental classification, we can easily understand. There are two ways in which the bones are developed. Either they form from membranous ossification, or they form from cartilaginous ossification. Basic difference is, in case of membranous ossification, the bone is directly formed from mesenchyme, directly. And not very number of bones are there having membranous ossification. Very few bones have membranous ossification, mainly the bones of the skull, some face, and a bit of clavicle, you can say. The rest, most of the bones in human body development, they come from the cartilaginous ossification. So what happens over there? The mesenchyme first forms the cartilage, mainly hyaline cartilage, H. Then it is replaced by ossification or ossified tissue, or osteoid to be more precise. That is how the bone is simple as that. So there are two classifications mainly. Then there is mixture of those classifications. Now let's see. So membranous classification ossifies in membrane, cartilaginous ossifying cartilage. Remember which cartilage it is? Cartilage over here is mainly H for hyaline cartilage. Membranocartilaginous mixture. Can I learn the example over here? Mainly the clavicle you can put over here, and a bit of mandible also you can add over. Somatic and visceral bones. Somatic are most of them are somatic, meaning by they come from this mesenchyme only. Very few number of bones which you will learn in, or which you might have learned in your head and neck embryology when you talk of the term known as pharyngeal arches. What actually happens over there, that there's a neural crest cells over there which are basically from the pharyngeal arches, and these neural crest cells, they are the ones which gives rise to bone in those 5 pharyngeal arches. For example, you have a high head bone, right? You have laryngeal cartilages. Okay, you have a bit of say mandible bone, middle ear bones are there. So they are basically known as visceral bones. They are coming mainly from pharyngeal arches. In this pharyngeal arches, the main contributor is NCC, is neural crest cells. It is neural crest cells. Okay, this is one classification developed. Then a region, which region? Again, quite a simple axial skeleton and appendicular skeleton. See, easy to understand. Axial skeleton, it forms the axis of the body. Okay, center axis. What is center axis? You have the trunk and the head neck. So trunk and head neck, this part is the axial skeleton. Appendicular skeleton are the 4 appendages in a normal human body, the 2 upper limb and 2 lower limb. That is appendicular skeleton. Now there can be confusion that the bones which are joining the appendicular to axial skeleton, will they form under appendicular or axial? For example, if I ask, or if I ask a question like, what about clavicle, which is forming a sternoclavicular joint and acromioclavicular joint? So it is basically, clavicle is helping in weight transmission of upper limb to the body. It is connecting appendicular to axial skeleton. Similarly, in the lower limb, we have a hip bone. So these two are the bones over there, but you have to make them fall under some category. They are connecting appendicular to axial skeleton. So they are per se are part of appendicular or axial skeleton. Per se, they are a part of appendicular skeleton. Remember that. They are a part of appendicular skeleton, including scapula. You can add over here one more bone known as scapula. Okay, so this thing clear. So we have seen 3 types of classification: shape, developmental, regional, structural classification also. It is a way to give answer to the question. So you have macroscopically, you have some parts over here. What are they known as? Compact and cancellous bone. Compact is more hard, ivory-like texture. Cancellous is mainly found in the ends of bone. So compact is where the bone is dense, texture is ivory, but extremely porous, like your shaft of a long bone, diaphysis, or the outer part of the shaft of a bone, compact bone. They are tough, ivory. Bones are very tough. It is not easy to fracture a bone. You need high force for having fracture of the bone. Second is cancellous. Cancellous is also known as spongy. It is not spiny or spony, it is spongy, right? So you have, it is also known as spongy. So it is spongy or trabecular bone. It is open in texture. So where it is basically found, cancellous bone, basically found in the ends of long bone. In the ends of long bone. You have the cancellous bone over there. This is one classification. Then you have microscopically, you have lamellar, woven, fibrous dentine. This is another classification. The more microscopically you can go, you will have more classification. But remember, basically three classification based on the shape. You should know developmental, regional classification, basic thing, and compact cancers also. Now coming to another question that easily comes is the blood supply for long bone. Okay, what is the blood supply for long bone? Some of you might be thinking, if you are studying it for the first time, that do bones have blood supply? Yes, they do have. Even they have very, very dense blood supply. Remember, during development and later on also after the birth, there is a bone marrow which is giving rise to blood cells. Yes or no? They are erythropoietic. They give rise to blood cells, RBCs, WBCs, hematopoietic. So it is inside the bones, the blood cells are being formed. So therefore, obviously, the blood vessel has to be there inside the bone. It is bone has a very highly dense blood supply. Remember that. So now, therefore, there is not single artery over here. First of all, let us see how many arteries are there. One is nutrient artery. And remember in anatomy, general anatomy, you have seen that nutrient artery, its direction is always away from the growing end of the bone. Direction is always away, or you can say is opposite from the direction of growing end of the bone. What does it mean? Let me tell you with a simple example. The direction of the nutrient foramen is learned by a mnemonic that to the elbow I go, from the knee I flee. Okay, so basically the nutrient artery direction is towards the elbow. It is what? It is towards elbow. So understand, and away from knee. So if you talk of upper limb, say for example, you talk of the upper limb that is towards elbow. So if you look at my hand over here, this is my arm and forearm. So this is the elbow, right? The nutrient artery direction is towards elbow. So this is the arrow over here, and from here to here, this is the arrow. So nutrient artery is going where? Towards the elbow. It means that the wrist and the shoulder are growing ends of the bone. These two are growing end, therefore the nutrient artery direction is opposite to it. So if someone asks you a simple question that in case of upper limb, or they give you just two options, wrist, elbow, which is the growing end of the bone? You will say, sir, wrist is the growing end. So in upper limb, mainly the wrist area and the shoulder area, they are the growing end. Now, some of you might be confused that what is growing end? Growing end means that it, see, this is the long bone humerus. So it will have one group of epiphyses over here and one group of epiphyses over here. Growing end means which group of epiphyses will fuse last. So you have two ends. So this upper end, that is upper end of humerus epiphysis, will fuse later than the lower end of humerus epiphysis. As simple as. So growing end are wrist and shoulder in case of our upper limb, and say opposite will get case of lower limb. So now coming back to the topic, that is blood supply. So blood supply, one is nutrient artery. A few points I told you already. First of all, let's see other arteries what are there. Then there is periosteal artery. Just remember their names. Nutrient artery will actually go inside the bone. Okay. Periosteal means it is related to the periosteum of the bone. And then epiphyseal artery and the metaphyseal artery. So we know what is epiphysis, metaphysis. So they are around those structures. You have to write around four things over there. Nutrient artery, what they are saying over here, that enters the cortex through the nutrient foramen, divides into these branches, and at the ends they form a hairpin loop. So in this image over here, which they have made, this over here is the end for nutrient artery. You can look over here, they are forming the hair loops. But when this is till the growth of the bone is not completed, because here this blue color is what? This is your epiphyseal line over here. Okay, so here it is your epiphyseal line. That is, the length of the bone is yet to be fulfilled. It is a growing phase. Therefore, the blood vessels will form a hair loop over here. And which area is this? This area is actually the metaphyseal area. And sir, what's the is there any clinical use of it? Why should we know so much in detail? The reason is that in the small children whose epiphyseal line is still made up of cartilage, it is not made up of bone. Bone is still increasing in size. If suppose any infection, if suppose imagine this green color infection enters into nutrient artery, that infection will stop over here at the there's hairpin loops that can give rise to infections. Osteomyelitis is what we normally call it as. Osteomyelitis means infection inside the bone. Osteomyelitis. That is a disease. Okay. While when the bones have epiphyseal line, when it has fused, then this hairpin loops they disappear. Then this vessel will directly go where till the epiphyseal like this. Okay, so remember that. So you've seen which artery was there. So okay, supplies metaphysis. So all these points are also over there. Periosteal artery. Okay, so numerous beneath muscular and ligamentous attachment. Epiphyseal artery from the periarticular vascular arcade is found near the bony surfaces, articular or non-articular. Metaphyseal arteries from neighboring systemic vessels. Meaning by that, see, we have a bone over here, imagine, and then we have a bone over here as well, right? But there are other arteries also which are running. Like what? Like suppose there is an artery going like this, like this. So these are the arteries which can give branches directly to inside the bone. They are known as your what? They are known as metaphyseal arteries. They derive from neighboring systemic vessels. They enter through the metaphyses. Okay. Long short bone nutrient artery enters in middle of shaft, divides into form of plexus, major part of bone supplied by periosteal artery. So in a long short bone, meaning by, for example, metacarpals and metatarsals, it is mainly the periosteal artery, because these every small bone will not have a specific nutrient artery. Nutrient artery is basically separate artery for very long bones, or the real long bones like humerus, femur, tibia, fibula, radius, ulna. These are the typical long bones. So nutrient artery is basically okay for these typical long bones. Others will have other arteries like periosteal or metaphyseal, epiphyseal arteries. Okay, short bones, vertebrae, ribs, all will have like this. Okay, same goes for the venous drainage as well. These are some of the diagrams that are given over here. Also look for the now your histology for case of bones, mainly the compact bone. What we see over there mainly is the Haversian system, Haversian canal system. We have a concentric lamellae over here, so you can concentric lamellae over here having the osteocytes in between. In the center, we have this Haversian canal, which is for the blood vessels and nerves, and they have the Walkman's canal as well. So that is all dealt in case of your histology. I'm just giving you some names over there. So if you look at a compact bone, you see a concentric circle of lamellae over there. In the center, we have the Haversian canal, right? So in the center, we have the Haversian canal, and perpendicular to the Haversian, we will have the Walkman's canal. Okay, so here you can see perforating canal. This will basically be a Walkman's canal, and Haversian canal will be going parallel to the long axis of the bone. Okay, so remember that part as well. Okay, now similarly to bones, we have understood what till now. We have seen that the types of bones and a bit of epiphysis, types of epiphysis, and blood supply of bones. Okay, basic ideas. Then coming to the cartilages. Cartilages again, they are nothing but a type of connective tissue only. Okay, so they're also a type of connective tissue only, composed of 2-3 things are basically main in the cartilage. First of all, where is cartilage? Cartilage is nearly present many places, right? Normally, cartilages are present between the bones inside the joints, connecting the bones also at few places. And wherever we like ear, we have larynx, we have nose, we have. In fact, as we have seen that during development of the bones, nearly the majority of the skeleton, which we are made up of, was initially only cartilage. And even the growth of the bones, it is also by cartilage. That is, remember that blue color line in the long bone, no? Epiphyseal line, that is also cartilage, hyaline cartilage. Cartilage is present at many places. There are mainly three types of cartilages. We have hyaline, we have elastic cartilage, we have fibrocartilage. Histology questions also come from this topic. Okay. So what is cartilage basically made up of? See, it will have some cells. Like the bone cells, we call them as osteocytes, osteoblast, osteoclast. Similarly, in case of cartilages, the cells will be known as like chondrocytes, chondroblasts. Chondro means cartilage, chondrocytes. Okay. Now, these cells of the cartilage, they are going to give rise to, so one number of cells, they are going to give rise to fibers, collagen fibers, elastic fibers, reticular fibers. And also, in between those fibers, you need some gel-like matrix. So there's also a matrix, or you can say environmental milieu. We call it the milieu, no? Environment. So in between, there's also a matrix which is formed. So basically, the cartilages are made up of these three things. We will have cells, we will have fibers, and we will have matrix. So cartilage composed of cells, fibers embedded in a matrix, which is basically your MPS mucopolysaccharide. Right? Right. Classification, as I told you, three: hyaline, elastic, and fibrocartilage. Most numerous is actually our hyaline cartilage only. Majority of the cartilage in our body is mainly hyaline cartilage. So hyaline meaning by what? Why do we call it as hyaline? What is the meaning of it? Hyaline means glass-like. So it appears transparent. It appears what? It appears transparent. Remember this word only. It appears transparent. It means that it does not mean that it has no fibers and no cells. It has everything. But to your eyes, because they have a similar refractive index, it appears transparent. Like, for example, between the camera and myself, there's a whole lot of air and a lot of stuff circulating in the air. But we are not able to see it. You're only able to see me directly and the stuff behind me. It doesn't mean there is nothing between me and the camera, right? Similarly for the hyaline cartilage. Okay. So where it is located in the articular cartilage of long bones, epiphyseal plate, nasal cartilage, trachea, bronchi. It is bluish white in color, shining, very thin fibers, flexible, perichondrium is present. So let me correct over there, perichondrium. Like we have periosteum covering the bones, we have the perichondrium which covers the cartilage. So this is basically where the hyaline cartilage is actually found. Let us see fibro. Fibro is more tough. So found where? These are the common things which are asked, that where are they actually found? Fibrocartilage is found in the intervertebral disc. TMJ is your temporomandibular joint. Inside this, you have a disc. Sternoclavicular joint, we have a disc. It is white in color, opaque. Numerous white fibers, mainly collagen, thick collagen fibers are there. Perichondrium is absent. Again, see, perichondrium is present, but it is not seen to our eyes. Therefore, we say it is absent. It is not absent, it is present. It is not just seen as a separate entity. Okay. Elastic cartilage, understood by the name, it is more elastic. So they are more elastic fibers. Located in pinna, okay, exfoliatory meatus. Eustachian tube, let me clear some spellings over here. Eustachian tube, epiglottis. It is yellowish in color. We have yellow fibers, flexible perichondrium. So in cartilage, you need to know that what is cartilage basically made up of. Three types of cartilage are there. Where are they actually found? Now coming to another very, very important topic, there is the joints over there. Joints, wherever two or more than two bones they meet, that place is known as minimum. There has to be two bones. Could be more than two also. For example, elbow and elbow example, you have humerus, radius, and ulna. They form the elbow. In knee joint, you have femur, tibia, not fibula, but yeah, patella we have. Okay. In ankle joint, we have tibia, fibula, and lower down you have talus. Okay, so normally two bones are always there in a joint, minimum two bones. So you need to have more than or equal to two bones at least. then only we can call it as a joint. Okay. Mainly the majority cases when we say of joints, we talk of the our which joints, the mobile joints, that are known as synovial joints. For example, moving upper limb and lower limb. Synovial means they have some synovial fluid by which they're easily mobile. The synovial joints. But for example, let me tell you already know that there are multiple bones in face and skull, but it is not like they are moving all the time. You cannot move your maxilla from zygomatic bone or frontal from nasal bone. They are all there, and they are separate bones, so they are forming joint, but they are not moving as our upper or lower limb. So apart from synovial, we have other joints which are known as fibrous joints and cartilaginous joints. So how do we classify it? Before going details, let us first have a good idea. Basic idea should be there. Majority of the joints are synovial. Okay. They have the synovial fluid between them, which is formed by synovial membrane, capsule, and all. Those joints are known as synovial. If between the two bones you only have fibrous tissue, you don't have any synovial fluid, you don't have any movement, that is known as fibrous joint. Example, sutures of our skull, they are fibrous. Which joint will then be known as cartilaginous? When you have hyaline cartilage also, and in between hyaline you have a fibrocartilage also. So you have more cushioning. You don't have a simply fibrocartilage, but you have additional cushioning. So in cartilaginous joint, you might have some movement. See, synovial joint will have a lot of movement depending on the shape of bone. Okay, for example, our shoulder moves more than our elbow. Our elbow is only moving in this direction, flexion, extension, but our shoulder is moving everywhere, this movement, that movement. Synovial joint will be highly mobile, and that degree of mobility will depend on the shape of bone. Fibrous joints will not move. Cartilaginous joints also, some of them does not move. Some of them will move a little, not as much as that of our synovial. Basic fundamental is this. Now let us see what is the notes. So junction between two or more cartilages bones is known as joint. Fine. So structural classification, they started these three: fibrous, cartilaginous, and your synovial joints. Okay, now fibrous joints, immovable or permanent slight movement. Basically, it is immovable. Three things you need to remember. Sutures of skull, one example I told you already, syndesmosis. Okay. We have syndesmosis. Syndesmosis is nothing but actually it is like interosseous membrane between radius ulna, between tibia fibula. It is also made of a fibrous structure only. And then you have a gomphosis between tooth and socket. So remember these three names by heart. You have sutures, you have syndesmosis, you have gomphosis. They fall under fibrous category. Primary, you have two names. One is, sorry, cartilaginous joint, you have two names. One is primary, one is secondary cartilaginous. Primary cartilaginous, we already have seen, that is your epiphyseal plate, no, epiphyseal line that we showed. Let me show you that again. Just a second. We are going to see, yes, over here. What we are going to see is this area. Focus over this area. So what you're seeing, a bone over here and a bone over here, B and B are bones. In between over here, the blue color, it is what? It is a cartilage. This is cartilage. If you take out an X-ray, X-ray will come like this. X-ray will come like this. White over here bones, and then there will be a gap over here. It is not that the bone has been fractured. There is bone over here, but it is what? It is your cartilage over here. So as cartilage is not radio opaque, so it is not seen on X-ray. So now what will happen is that this joint is what we call it as a primary cartilage, because there's only cartilage over it. But after some time, that this primary cartilaginous joint, it will be replaced by bone, as I told you, because this hairpin is only present in small children. Therefore, primary cartilaginous joint is temporary joint. It is known as synchondrosis. Now let us move back to our discussion over here, right? So if you see over here, primary cartilaginous is synchondrosis. It is temporary in nature. Okay. Secondary cartilaginous is present mainly across the midline of the body. Examples like intervertebral disc, then pubic symphysis, mental symphysis between the manubrium and the body of the sternum. All these areas you have secondary cartilaginous. They are slightly moved. They are known as symphysis. Remember this, cartilaginous has two varieties. One is primary, one is secondary. Primary is temporary. It is known as synchondrosis. Secondary is not temporary. It is the permanent. Mainly the secondary joints are present close to midline of the body, like intervertebral disc between the vertebrae body, pubic symphysis, mandibulosternal joint. All. Then comes the last one, the most famous one and the most numerous one is the synovial joint. I already told you, most evolved, most mobile. But depending on the movement, depending on the movement is based on the shape of the bones. The synovial joint again classified into so many names over here. You can see all this ball and socket, saddle, bicondylar, ellipsoid, hinge, pivot, shoulder, all of this. Now this becomes a task. So let me help you over here by making you understand this. How to classify the synovial. It is simple. Classification of synovial joint will be based on the degree of movement, simple as that. So remember at least one classification so that it will cover everything. So based on the degree of movement, we classify the synovial joint. Now see how to classify it. First is when the movement is non-axial. It is not on any axis. It is basically bones are sliding against each other. Okay. Second classification will be uniaxial. That is movement only at one axis. It can be transverse axis, horizontal axis, or vertical axis, but only and only one axis. Then movement along more than one axis, around 2 plus or minus somewhat 2.5 or 1.5. So movement will be around two axes, biaxial. And the classification will be multi-axial, movement around all the axes. Now, which type of joint will fall under which category? Let us see that. Non-axial joint will basically plane joints, plane synovial. For example, I'll give you examples as well. But just listen to this 5 minutes. The plane joints are basically intercarpal joints. So these ones over they slide against each other. Uniaxial along one axis like hinge joint and pivot joint. Examples: hinge joint, like the hinges of the door. Elbow joint, only one axis movement. Pivot joint, moving your head from right to left, only one axis, vertical axis. Then biaxial joint, condylar joints are biaxial joint. Okay, for example, fingers between this metacarpal, that is the phalanges. So metacarpal phalangeal joint, knuckle. You have flexion extension, and you have this movement also, adduction abduction, condylar joints. Multi-axial will have examples like saddle and ball and socket. Saddle and ball and socket. Ball and socket, I am sure that you all must be knowing. Ball and socket is your shoulder joint. Saddle variety will be where? Saddle variety, let me give you a couple of examples over here. Saddle variety, one example, remember sternoclavicular joint. This joint over here. You might not feel like that, okay, sir, but this joint, when does it move? If you keep your finger over here on the sternoclavicular joint and you move your upper limb, you will feel the movement actually. Other joint over here will be the first carpometacarpal, first CMC joint, carpometacarpal. Basic classification is this. Then let us see. So functional classification is given over here. Synarthros, syn means fused, so it is immobile. Di means separate, so they are freely mobile. So which joints will come under diathrosis? Synovial joints. Synarthrosis will be basically fibrous joints. Somewhat movement, secondary cartilaginous. Okay, so synarthrosis, syn means fused. Joint is fused, so it will not be able to move, so it is your fibrous joint. Diarthrosis, joint bones are separated, easily mobile, so synovial. Amphi means in between, like amphibians. They live in land and water. Amphiarthrosis. Just move a little. Secondary cartilage. Okay, so one is this classification. The regional classification according to regions, we have skull, vertebrae, and limb. Okay, according to number of articulating bones, yes, you can, for sake of the answer writing, you can simple compound complex. Simple is when only two bones articulate, only two bones, it is simple. Compound, when more than two bones articulate, is compound. Then what is complex? When there are only two bones, but in between you have an intra-articular disc. Examples. Some examples we already discussed, like example over here will be temporomandibular joint. Okay. Example over here will be our what? Okay, temporomandibular joint, sternoclavicular joint. They have disc in between. Even wrist joint, that is radiocarpal joint. Wrist is what? It is radiocarpal, between radius and the carpals. They also have disc in between. That is complex. Okay. Now let us move ahead, and types of synovial we already have discussed, but most evolved joints are synovial. Just let us go through it. Examples we will see one by one. Plain, I just gave you examples of intercarpal, intertarsal joints. Other examples also there. Hinge joints, I gave you an example of elbow. You can also add ankle over there. These are uniaxial. Pivot again are uniaxial. Like you're moving your head, so it is median atlantoaxial joint, radial joint. Pronation, supination, uniaxial. Condylar, bit of biaxial. You have knee and TMJ. Knee joint will have two femoral condyles and two tibial condyles. Between you have patella also. TMJ again, you have two condyles, right and left. Condyles of mandible. Ellipsoid, yes, there's also one variety, ellipsoid. This also comes under the biaxial variety only. Like wrist joint, radiocarpal. Okay, you can flex, extend, you can also adduct, abduct the wrist. Okay, moving into axis. Saddle joint, multi-axial. If you remember, I gave you a couple of examples of first carpal, metacarpal, and your sternoclavicular. Okay, so you have both two examples over there. Sternoclavicular and first carpal, metacarpal. Ball and socket, again, multi-axial joint. Shoulder hip, very famous examples of this. Okay, so these are your types of joint. Very important question comes from it. Then let us see about the type of karyotyping. Karyotyping, a part of a bit of genetics as well. Okay. So before moving to this, let me again tell you the joints as a topic is very important. Joints as a topic is very important. You should know how to classify the joints. Fibrous, cartilaginous, and synovial. In cartilaginous, remember, we have two varieties more, primary and secondary cartilaginous. Then at least one example is obviously bare minimum. Then come to the synovial joint. It has all different varieties, but this, if you just try to remember, this might be a bit complex. Try to remember on the degree of their movement, movement in no axis, one axis, two axis, multiple axis. And then you have classifications, you have simple, compound, complex, all that, and then you come to the synovial examples. How do they move? That's it. Now coming to a bit of karyotyping. Karyotyping, genetics, simple. Few syndromes over there. Okay. So it is also known as ideogram. It is a standard arrangement of metaphase spread of chromosomes in decreasing length. That is the definition of the karyotyping over here. Okay. Chromosomes are identified on the basis of length of the arm and position of centromere. We divide the chromosomes. We all know that there are 22 pair of autosomes and one pair of sex chromosomes. So 22, total 46 chromosomes we have, 22 pair of autosomes and one pair of sex chromosomes. Total we have 23 pair, that is 46 number of chromosomes. Basically this. What is the procedure while doing karyotyping? That is, you can simply write in form of this flowchart over here. You can easily see. Okay, basically phytohemagglutinin is used, arrested at metaphase. Some key points over here which you should not miss. PHA, arrested at metaphase. Okay, and chromosomes are spread on obviously microscope, but there are other things also, but in decreasing order is what you have to understand. Karyotyping helps to identify the pattern of abnormal. So these are the benefits. Why do we do? First, the question is now why you are doing karyotyping. You have to see any abnormal chromosome. Some chromosomal defects are there, which you'll see, and obviously many cases now gender disorders might be there. So determination of sex, so it is also helpful. Okay, so there are few bands, spinacrin. There are few syndromes like Down syndrome, Klinefelter, and Turner syndrome. These are three basic, very famous syndromes which you should know. Down syndrome is trisomy 21. So in karyotyping, you'll see in 21, 21st pair, you have three pair of chromosomes. That is Down syndrome. Most common congenital anomaly due to numerical aberration of first described by Dr. Down. It's most common. Trisomy 21st chromosome. Okay, so you write it by 47XS or 47XY. It is a male, then 47XS. 47XY, it is a female 47XX. Okay. Clinical features, should know all these clinical features. Better to make a diagram also of a boy with a poor growth, widely spaced, great toe. Then there are simian increase also you can make. Okay, moon face, short-headed. You see a lot of Down syndrome patients. A lot of Down syndrome patients. You can see a lot of movies based on Down syndrome, both in India as well as abroad. Okay, and you'll see also a lot of people in our surroundings. They have Down syndrome. If you see them once or twice, you'll recognize them easily. Okay, that is Down syndrome. Don't make a diagnosis by this. Then you have Klinefelter syndrome. Okay, we have over here, remember, it is 47XXY. This is the main thing over here. It's a male only, but with an extra X chromosome. You have what? You have extra X chromosome, simple as that. So normally there's no bar body in males because bar body is only seen when there are two X chromosomes. But here, a male with a bar body is the Klinefelter syndrome. Of course, due to meiosis II non-disjunction, some clinical features like a small degree of mental retardation, a small testes linked to infertility, normal penis and scrotum, gynecomastia, scanty pubic and facial hairs. Finally, a Turner syndrome. Turner syndrome is what? Simply can 45X. So there's one missing X chromosome over here. One missing X chromosome. Basically, it's a female with absent bar body. So there are no bar bodies seen over here. Few clinical features are over here. Female having short stature, webbed neck, low set ears, okay, cubitus varus, amenorrhea, widely spaced nipples, rudimentary ovary or streaks gonads seen over there. So these are the features of a Turner syndrome. Treatment is replacement therapy and all. So remember, there are three main syndromes. Other syndromes are also there. The Edward syndrome, you have Patau syndrome, there's so many syndromes. But out of these, the most common is obviously Down syndrome. So you should know all the features. Remember all the features and try to make a diagram. Not a diagram, but a diagram of a baby with an arrow, show all the features. And after Down syndrome, there are two famous syndromes, Klinefelter and Turner syndrome. This is what one should be knowing. Minimum basic requirement is this. So wrapping the session, basically session was of the general anatomy. I again request you the topics that we covered up today. In sequence wise, if I tell you, most important is the joints classification. Then comes the bones. In bones, basically blood supply is frequently asked, and also remember the applied aspect as well. And there's a time to understand what is cartilage. And I advise all of you, as you are listening to this carefully, then after this topic, go to the histology of these two areas, at least bones and cartilage. Look at the histology, you'll understand more in detail. Histology of bone. In bone histology, we have compact cancellous and also histology of a growing bone. In cartilage, all these three, hyaline, elastic, and fibrous cartilage, their histology. Cells, fibers, and matrix is what you need to see. Then obviously, for exam point of view, your theory exam, look at the Down syndromes, the Klinefelters, and the Turner syndrome. Klinefelter and the Turner syndrome. These specific clinical features should be at the tip of your tongue. One is trisomy 21, one is 47XXY, one is 45XO. This is our karyotype, right? Okay, so that's all. And look at this. You can have a look at this slide again. These are all the courses, and you can use this code also, Dr. Ankit 20, to avail some discounts and subscription. That's all. Thanks for watching, and do follow our social media handles. Look at other videos as well as on our Oracle YouTube channels, Insta, Facebook, and Telegram as well, right? So that's all from my side. I hope you enjoyed. Thank you, and see you later. Bye bye.